Welcome back in another discussion of Index TB guideline. In this discussion, we will discuss about the monitoring and follow-up a patient of lymph node tuberculosis. These are the common questions we all face. Common question asked by the patient that sometimes they are on treatment and they say their size is not decreasing, and sometimes they also say that I got a new nodes and they ask that is something else, कोई और बीमारी तो नहीं है, or it is something malignancy or some other diagnosis is there or not. They are worried about that, and sometimes they say that size is increased and it becomes fluctuant. Sometimes swelling enlarges and they say there is a sensation of fluctuation in the node, and they also ask when the lymph node will disappear because of the cosmetic region and various issues. And sometimes the lymph nodes are still there, although small in size. Should ATT be continued? How long? They ask that lymph node size has decreased, but will it be there? When it will disappear? And should I continue my ATT for a longer duration? And can it reappear or relapse? So these are the certain questions that comes from the patient perspective when we treat the patient of lymph node tuberculosis and we see in that our day-to-day practice. So our discussion for today will be focused on this, and we will try to understand that how these questions can be answered based on the monitoring and follow-up of a lymph node tuberculosis. All right. So if you see from the physician perspective, when we start treating a patient of lymph node tuberculosis, we have to certain point we have to think of that when to assess the treatment response, how to monitor, how to follow up our patient, and what are the partial responders, what is treatment failure, what is the drug resistant cases, and what is paradoxical response. So we will discuss all these things. By knowing this, we will able to answer in a better way about the patient perspective that we have just seen. All right. So when to do a first assessment in lymph node tuberculosis, for example, it's a cervical lymph node, or it's a, whether it's a mediastinal lymph node, or maybe it's abdominal lymph node. When to do a first assessment? So if you refer to the Index TB guideline that is released, so if they are saying that assess response to treatment at 4 months, you see the response of treatment that we have prescribed to the patient, assuming that the regime was appropriate, is taking the medicine regularly, and it is a very compliant treatment, doses are appropriate. So we should assess the treatment response at 4 months. All right. And treatment failure or alternative diagnosis should be considered in the patient who have worsened or deteriorated after initial improvement. What are the most common cause of failure is that is your compliance issue. This we most commonly see in our OPD setting, that is a compliance issue by the patient. Sometimes they are the poor compliant with antitubercular treatment, and it is followed by a poor absorption and a drug resistant cases. So that comes later. Poor absorption, drug resistant is the next cause of failure, but the most common cause is your compliance issue. Ruled out the treatment failure and alternative diagnosis, that okay, treatment failure is not the case, or alternative diagnosis does not seems to be. So in that situation, we should think of paradoxical response. We will discuss in a detail in a subsequent slides. So first we have ruled out that there is no failure of the treatment and there is no alternative diagnosis for the patient condition. After this is ruled out, we have to think of paradoxical response, paradoxical reaction that the patient is having, leading to his worsening of the symptoms. All right. Some patient with lymph node tuberculosis may have residual lymphadenopathy at the end of the treatment, and this does not indicate ongoing active TB infection if the largest node is less than 1 centimeter in size. This size we should always keep in our mind. So some patient with lymph node tuberculosis may have residual lymphadenopathy even at the end of their treatment. So their lymph node may persist, and that regress over time. Coming to the partial responder, what we call partial responders? If you treat some patient and we found that we have seen that some patient have residual nodes more than 1 centimeter in size, these patients are classified as partial responders. If after treatment patient has responded, but their lymph node size is more than 1 centimeter, so these patients are called as a partial responders. All right. So how to take a step in partial responder, how to deal with them? There is an uncertainty about whether continuing ATT in this patient is beneficial. Right? While some evidence suggests that this patient may not require further ATT, the data is insufficient at this stage. But the experts are saying that okay, in partial responders, although they are responding poorly to treatment and their lymph node size is more than 1 centimeter, so the expert group suggested that this patient should receive additional 3 months of HRE, that is isoniazid rifampicin ethambutol, followed by a biopsy, and that should be sent for the histology and the TB culture. So how to follow a case of mediastinal lymph node? In case of mediastinal lymph node, improvement on the ATT can be monitored with a serial X-ray. If you do a serial X-ray, we can see the size of lymph node is decreasing. That means the patient is improving on anti-tubercular treatment. CT scan sometimes be indicated when lymph node do not reduce in the size after 4 months. So if we see that lymph nodes are not regressing, so we should wait for the 4 months and then we can do a CT scan to look for the resolution of the lymph node. All right. And if the patient who failed to improve on anti-tubercular treatment, the alternative diagnosis always of the lung cancer like lymphoma, sarcoidosis, fungal infection should also be considered. That comes in a diagnosis of mediastinal lymphadenopathy. All right. And here question comes, when to stop anti-tubercular treatment in case of mediastinal lymph node tuberculosis. So in patient with a persistently enlarged mediastinal lymph node, stop ATT when there is an absence of interval change in CT or MRI of mediastinal lymph node for more than 4 months with the resolution of all other clinical signs. So this is the criteria when we can stop anti-tubercular treatment in case of mediastinal lymph node tuberculosis. There is no change in the 4 month of follow-up scan, and also there should be resolution of the clinical signs and symptoms. Patient should have gained weight, his anorexia, asthenia, general health must have improved, his weight loss that was initial in the disease progression, he must have gained the weight. So his symptoms and signs must be improved, that must be resolved along with your no interval change. Maybe lymph node size is not changing in the interval of 4 months. In that situation, we can stop the anti-tubercular treatment in case of mediastinal lymphadenopathy. What are the additional problems that we can encounter while treating the patient of tuberculosis is there may be appearance of the new nodes. We know enlargement of the existing node. The existing node may enlarge. There may be development of fluctuation. There can be abscess formation. There may be sinus tract formation. There may be residual lymphadenopathy after completion of treatment. Lymph node may be there, and there can be a risk of relapse also. What are the possible explanations for this? Here comes poor patient compliance to treatment. This is the first and most common part. Poor patient compliance. Patient do not take sometimes their anti-tubercular treatment effectively, so they are not compliant sometimes. So that is the most common factor we should look for. Then second point is unidentified drug resistance. Sometimes patient have a background drug resistance in case of monodrug resistance or a polydrug resistance, or for that matter rifampicin resistance cases also. So if that drug resistance is not identified at the start of treatment, there is a chances of failure. And third point is poor drug penetration into the lymph node or poor absorption. This is another factor for this. There may be unfavorable local milieu, that lymph node is a distant site that is located to the area where drugs are not possibly able to penetrate, or the drugs are not available to act. There may be NTM infection, non-tuberculous microbial infection. In that situation also there may be a new nodes, or there may be poor response to the therapy. There may be enhanced delayed hypersensitivity reaction in response to microbial antigen related during medical treatment of disease that we see in the paradoxal response especially. There may be superadded infection, resistant cases like INH mono or resistant MDR or RRTB cases, and there may be alternative diagnosis like malignancy, Kikuchi-Kuruma disease, and Fujimoto. So these are all the causes. They are also all the possible explanation for the additional problem. These are the additional problem that we face, and this could be the reason. So first and foremost is important your poor patient compliance. We have to address the compliance while we're treating the patient of tuberculosis first. So monitoring and follow up a lymph node tuberculosis patient. First point is do a baseline general examination to document all the possible sites of lymph node involvement, including nature and size of involved lymph node. So beforehand, when we start treating the patient of tuberculosis, we should look other sites are involved or not, or we should document in our case sheet or in the OPD paper for that matter that what are the sites that were involved when we started the treatment, so that we can document that resolution is there from this particular site, and number of lymph nodes if we count, so that is also number are also decreased. So in that situation we can do a general examination, we can document in our case files. All right. So and now if there is appearance of fluctuation of one or more lymph node, that calls for aspiration under aseptic precautions. If during treatment, if then any lymph node enlarges and there is a formation of pus or the lymph node appears fluctuant, it's better to do an anti-gravity pus aspiration and do for a pus culture, and also look for the rifampicin status if that was not done at the start of treatment, to rule out the drug resistant cases and also the response to the therapy. It will also give an idea about any secondary bacterial infection that should be dealt with appropriately, and that may also include incision and drainage in some time. So if the node is secondary affected, secondary infected also, in that case incision and drainage can be needed. Okay, this is a very important point. Worsening after 8 weeks, that is 2 months of therapy, may call for en bloc resection of involved lymph node chain to avoid the appearance of a sinus tract. So after 2 months of therapy, if there is a symptoms are worsening, in that situation better to take out the lymph node en bloc and send them for culture, AB culture and histopathology. All right, and we should always do a en bloc. Excision biopsy, excision is very preferred, not incisional, because if you do an incisional biopsy, the chances to formation of sinus tract is more. So it is preferred to take the lymph node en bloc, like excision biopsy. All right. Sometimes non-healing sinus tract may need resective surgery in that situation. So, all right, if you see residual lymph nodes after completion of treatment, observe closely. So, if lymph nodes are still there after treatment is completed, how to do? We should observe closely, because we know that lymph node regression can take time. So, any increase in the size or appearance of symptoms calls for external biopsy, histopathology and culture. Most of these patients will respond to retreatment with the same regime. So, we have started a treatment and patient has responded to treatment, and but the lymph nodes are still there after treatment is completed. So what to do in that situation? Number one, observe closely. Look for the appearance of new signs and symptoms if the patient is having or not. If the patient is clinically improved, signs and symptoms are improved, resolved, so in that situation we have to keep this patient under close follow-up. However, if this patient develop new symptoms, lymph node size getting increased, or there is a appearance of new nodes, more fluctuation, or constitutive symptoms, so in that situation we always go for an excisional biopsy, send for histopathology, MGIT liquid culture or AFB culture to rule out failure, to rule out relapse, and also to look for the rifampicin resistant cases and to rule out the resistant cases in that situation also. And if the patient comes out to be rifampicin sensitive, they will respond to your retreatment same regime. And all efforts should be made to isolate the causative organism and to obtain prompt sensitivity testing, particularly in relapse cases, non-responders, and drug modified accordingly. We know that in case of relapse cases, we should always look for the drug resistant cases by the appropriate genotypic testing. We do a CBNet, we do a gene expert to rule out the drug resistant. All right. Some patients with lymph node tuberculosis have residual lymphadenopathy at the end of the treatment, and if that is a more than 1 centimeter size, such patient may be partial responders. We have discussed in that situation we have to give additional 3 months of therapy. We have to extend the CP of HRE followed by a biopsy, and that should be sent for a histology and a TB culture. If the 5 lymph nodes are residual fibrotic, so ATD need not be extended. So it is only extended in case of partial responders which have a more than 1 centimeter of lymph node size left after the end of treatment. Little bit of the paradoxical reaction. What is this? Paradoxical reaction in tuberculosis is defined by a clinical or radiological worsening of pre-existing tuberculosis lesion or the development of new lesion in a patient receiving anti-tubercular medication who initially improved on treatment. So this is very important to know that it is defined by a clinical radiological worsening of pre-existing tuberculosis lesion or new lesion in a patient receiving anti-tubercular treatment who initially improved on treatment. This is very important to know, who initially improved on treatment. So that we call as a paradoxical response. And remember, it is a diagnosis of exclusion as we have discussed earlier. What is the timeline? When does it happen? It could be as early as 2 weeks and as late as 18 months after the initiation of anti-tubercular treatment. So it can happen in the early 2 weeks or as late as 18 months after the ATD started. So how to approach? So on ATD, if there is a worsening of symptom of the patient, and if it is early, that is less than 3 months, we should think of paradoxical response. And if it is late, that is more than 3 months, we should always look out for the drug resistant in that situation. So usually in early, less than 3 or 4 months, we should think of paradoxical response, the patient who initially improved on treatment, and late we should always rule out drug resistance. It is often self-limiting, but sometimes it can turn out to be serious, and on rare occasion, it can cause the death of the patient also. Although the exact mechanism is not understood of paradoxal response, it is said that it is due to abnormal immune response or restoration or reconstitution of the immune system. For this reason, paradoxal response is more commonly seen in case of HIV co-infected individuals. All right. So what happens in PR, paradoxal reaction, a rise in the lymphocytic count, a tuberculin conversion during treatment, and disseminated disease may have all associated with the development of paradoxical response. So these are the features of paradoxical response. So what is the key point in paradoxical reaction? It is deterioration in the first 3 weeks to 4 months, maybe due to paradoxical reaction, exclusion of alternative explanation to the clinical deterioration, and it is more common in the HIV infected, that within 2 months of combination ART therapy is started. How to manage a case of paradoxical reaction? We have to continue this ATT. This is very important that we do not, this is condition where ATD is not stopped. We have to continue the antitubercular treatment. We have to do a symptomatic treatment, NSAIDs for pain, and you can do a USG guided aspiration in case of fluctuation or new nodes having a increased size, or there may be a fluctuation CG material. So in that situation, we should do a USG guided aspiration and send for the culture. So how to do a follow-up? We should follow up a clinical response. When we started a patient of tuberculosis, lymph node tuberculosis, we should do a clinical follow-up 1, 2, 4 and 6 months. 4 month, we should assess the lymph node size that we have discussed, and clinical response, we should always look every month, first, second, 4, 6 months. So in the first month, we should look for the clinical resolution. Means his symptoms of the patient must have been improved, that or maybe improving. His anorexia, weight loss, low grade fever that are persisting, they should start improving. Okay, so we should do a clinical follow-up 1, 2, 4 and 6 months, and we should consider the possibility of treatment failure in the patient who have worsened and deteriorated after initial improvement. Those patients who are deteriorated after initial improvement, we should always look for the treatment failure in such patient. And imaging, we should do repeat imaging if it's clinically indicated, and if there is a development of fluctuation, we should always do a ultrasound guided aspiration and send for the culture, AFB culture, and also if possible you can do a histology or a cytology. If there is a frank pus, we should do a AFB culture, and we can repeat a CVNet or gene export also for that matter. If there is a sinus tract, any worsening after 8 weeks of therapy, we should do an en bloc resection of the involved lymph node chain to avoid sinus tract formation. And some patients of lymph node TB have a residual lymphadenopathy at the end of treatment, and it is more than 1 centimeter size. In case of partial responder, clinical features have persisted or reappeared, additional 3 months of HRE followed by a biopsy that should be sent for histology and TB culture. If residual fibrotic lymph nodes are there and clinical features have resolved, this is very important, clinical features here are resolved, ATD need not be extended. So in partial responders, lymph node size is more than 1 centimeter, number 1. Number 2, you can see here clinical features have persisted or reappeared. This patient still may say that my weight is not increasing, or they still may having anorexia, they are not improving as they should improve, or they may have a new onset of fever, they may are starting having new symptoms. So if their clinical features are there and their lymph node size is more than 1 centimeter, that we call as a partial responder. In that situation, you should extend the continuation phase 3 months of more of your HRE followed by a biopsy to look for the histology and the TB culture for that matter in this patient. But in the residual fibrotic lymph node, here clinical features have resolved, so no need to extend the antitubercular treatment. So after this discussion, we can answer these questions. Size not decreasing, answer may be yes. Some patient may have a delayed response, so we should better have a close watch for this patient. We have to tell them yes, we come to the regular follow-up. Some patient may have a delayed response for that matter, so there is nothing to worry. If everything is all right, if compliance is checked, the doses are checked properly, and diagnosis is also checked. All right, got new nodes, we know that there may be appearance of new node, so that is not an indication for there is not a bad sign sometime always. So we should always look for, and in this situation we should look for the paradoxical reaction and other things also, as we have discussed. Is it something else the patient asks, so you can tell them, that no, it's a tuberculosis if we are fairly confident in our diagnosis and we have done a FNSC and we have done the biopsy at the start of treatment. Size increase looking fluctuant. We can say that size can increase, it can decrease, and it can turn into fibrotic. It can turn out to be abscess formation during the course of treatment. So that is a normal course of lymph node tuberculosis. When lymph node will disappear, it's a long question. We have to tell them that it's a long time. Sometime will take to disappear the lymph node, or they can be a residual fibrotic. They can be remain fibrotic, and they can dissolve in a pretty long time. So that is not the thing to worry much if clinical features, clinical symptoms of the patient is improved. All right. Lymph node is still, although small in the size, should ATD be continued? So you can answer no. Lymph node are less than 1 centimeter. Clinical signs symptoms are improved. So no need to continue anti-tubercular treatment. 6 months to 9 months. 9 months in case of partial responder, and 6 months in the patient who are responded very well is more than enough for a lymph node tuberculosis. Can it reappear, relapse? Yes, tuberculosis can reappear, relapse. You have to tell them that yes, these disease can reappear, relapse, and you have to tell them the signs, symptoms, so that when they should come back to contact us. So these are the questions. Hopefully this discussion is useful to find out the answer of these questions. So stay tuned. In the upcoming videos, we will discuss much more important topics and the more clinical questions about the extrapulmonary tuberculosis in the coming videos. So stay tuned, keep watching, and if this video is informative, share among your friends and the physicians who are involving in the tuberculosis care. And stay tuned, keep watching.